let me start off by saying hello to everybody, and obviously thanking John, Joan, and LIVErNORTH committee for the invitation to speak today. I really appreciate it. It's quite nice to provide a bit of an update on fatty liver disease. And what I'm going to hope to do over the next few minutes is talk a little bit about some of the developments globally in fatty liver disease, and also highlight some of the research that's been going on in Newcastle and how we've been trying to move the ball forward a little bit in that respect. So those are my disclosures, which is just worth taking note of. Okay, so if we take a step back from fatty liver disease and just remind ourselves why this is such a challenge. The issue here is that globally, more and more of us are becoming overweight or obese. And you can see this very nicely here from data from Public Health England from a few years ago, where that bell-shaped curve has moved slowly to the right if you compare the dotted lines to the solid lines for men and women. And you can see how people who were of a healthy weight, it's tending to be more of them are overweight. People who are overweight, more of them are tending to be obese. And it basically means that all of us are carrying a few pounds more in terms of fat than a generation before. And when we think about fatty liver disease, therefore, the best way to think of it is as a multi-system disease. And it is just one organ and its response to this challenge that obesity, metabolic stress, systemic inflammation, and scarring causes. So from the organ nearest my heart is, of course, the liver, but similar processes are taking place in the kidney, the heart, our blood vessels, the pancreas, and all of these lead to specific kinds of illness that need to be addressed. Just to remind ourselves a little bit of the terminology, because I'll use some of these terms as we go through it. Non-alcoholic fatty liver disease is, if you like, the umbrella term, and that can be divided up into steatosis, or NAFLD, as it's sometimes written, steatohepatitis, or NASH, and then obviously increasing scarring that can lead to cirrhosis. And to make a diagnosis of fatty liver disease, obviously other causes of liver disease need to be excluded, and particularly and importantly, high alcohol consumption is excluded. So this is not a disease caused by alcohol consumption, although we will talk a little bit more about the complexities of that. And we know that fatty liver disease is strongly associated with being overweight, high blood pressure, high cholesterol, diabetes, and what's called the metabolic syndrome when those things come together. In terms of global prevalence, the data we have suggests that basically about a quarter of the adult population in Europe, North America, and most of the rest of the world has some degree of fatty liver disease. In terms of how many have NASH, it's somewhere in the order of 3 to 15% of people, depending on how you look at it. And as our weight increases, the more likely we are to have fatty liver disease. So 2/3 of people who are overweight will have fatty liver disease, and almost all people who go into the clinically obese range with a body mass index of greater than 30 would be considered to have fatty liver. When we look forwards, and prediction is something that, of course, is very hard to do for any situation, the trend is of a steady increase in the number of people with fatty liver disease. This is a modeling study that we did a couple of years ago, looking at countries worldwide, and I've highlighted the data there from the UK. Although the boxes in terms of more advanced fibrosis, F3 and F4, are relatively small, this still means that there are many hundreds of thousands of people predicted to be moving towards cirrhosis as a result of fatty liver disease in the next 10 years. So this is a major public health challenge for us in the UK, but actually, again, in most of the developed world. So really something that we need to consider. So with that in mind, what I'm going to do is I'm going to talk a little bit about sort of 3 broad themes of research and where things are at the moment. So a little bit about pathophysiology, in other words, understanding how the disease develops, what's going on, and then the natural history, what are the outcomes of the disease. I'm going to talk a little bit about how we're trying to improve the diagnosis of fatty liver disease and how we can better stratify risk for people so that we can inform patients better about what's actually going on in their livers. And then I'm going to talk a little bit about some of the work going on to try to find better ways of treating fatty liver disease, because as many of you knew, right now our treatment options are quite limited, and we're very keen to explore new ways of treating the disease. So let's take the first two of these together, really. A little bit about natural history, and then on to diagnosis and risk stratification. So there's this paradox that really underpins fatty liver disease. As I've said to you, 1/4 of the adult population have fatty liver disease, but the reality is, fortunately, only a very small number of those people are going to come to harm as a result of it. And you know, that is important because, of course, we need to, as doctors, I need to find the people who are more likely to come to harm so that we can focus things on trying to prevent that happening and to treat it as best we can. And that is one of the key challenges, if you like, seeing the wood for the trees. And it's also one of the reasons why historically, although fortunately this is improving, in primary care, patients have not always been referred on because primary care is seeing so much fatty liver disease, and the vast majority of people do not come to harm, fortunately. Therefore, there is a tendency to believe that no one will come to harm, which unfortunately isn't correct and is not the case. So historically, we've always believed that the progression of fatty liver disease was a straight line. You got fat in the liver, you got inflammation in the liver, that led to scarring and cirrhosis. But some studies done, including work in Newcastle on our multi-biopsy cohort, but also studies from North America and from Sweden, have really helped us to understand the natural history of fatty liver disease and appreciate that it is much, much more complicated than just A goes to B goes to C. So the easiest way to think of it is there are two phases to fatty liver disease. There's this left-hand side here, this dynamic steatosis, steatohepatitis process, where individuals are going back and forth from just fat in the liver to fat and inflammation in the liver. And then that damage that inflammation causes as it pulses through the liver then leads to a scarring response, with some individuals progressing quite rapidly all the way to cirrhosis, and other individuals progressing very slowly or not progressing at all. And again, both of these aspects are bidirectional. Things can get better or worse. In terms of how the inflammation affects the liver, I think the easiest concept I've ever come up with for this is to think of it as a sound wave. So the pulses of inflammation as they go through the liver may be very frequent and mild, or may be very frequent and very severe. And of course, each of these variations in terms of low frequency, high frequency, greater severity, lesser severity, all help to determine how damaging that inflammation ultimately is to the liver and how hard we're pushing the accelerator on fibrosis. And then that fibrosis is itself a balance between progressive laying down of scar tissue and the body also trying to heal and reabsorb the scar tissue. And all of this is being driven and influenced by a combination of our environment, be that our diet, what we're drinking, the bugs that live in our gut, medicines we're taking, and so on, and then our genes, which are the backdrop for everything that's happening. So it's a hugely complicated natural history, which this is really something that we're only now beginning to appreciate, and it helps explain that variation between patients. You know, two people may be similarly have similar degrees of diabetes and so on and so forth, and yet may have very different disease outcomes. This is the model that helps us to understand that and helps us therefore to understand how we can best address it. In terms of working out what those genetic factors are that influence individual susceptibility for fatty liver disease, we've just conducted the world's largest genome-wide association study for histologically characterized fatty liver disease. Now, this is one of the benefits of the European NAFLD registry that, of course, LIVErNORTH has supported now for a number of years, and I'm very grateful to LIVErNORTH. It's allowed us to assemble a very large cohort of patients who've undergone liver biopsy. So we have a large number of individuals. We've been able to capture a large amount of variation in terms of disease severity in these individuals. And then we've been able to use that to look at every common genetic variant across the entire genome of these patients, and then look for patterns. In other words, are there certain variants that are more likely to be associated with inflammation in the liver, more likely to be associated with scarring of the liver, or more likely to be associated with, for example, hepatocellular carcinoma. And we've identified a number of these variants now that have been associated with the severity of the disease. This is just a very brief summary of it, but the nice thing is we've been able to look at it, as I said, in a large cohort of patients, almost 1,500 individuals in the Genome-Wide Association study, and then a separate cohort where we've been able to double check our findings to confirm that they are correct. And some of the variants that have come out, for example, PNPLA3, I'll mention to you in a moment, TM6, and then GCKR, which is a modifier of insulin sensitivity, essentially. So highly biologically plausible. And what this means is we now are at the position where we've identified a huge range of genes affecting each of the phases of the damage within the liver, and each one of them modifying it. Some of them making us more sensitive to liver damage, such as PNPLA3 variants, others such as HSD17B13, where variants there actually help protect us from liver damage. So we're beginning to understand what it is that explains why some of us are affected more severely by fatty liver disease than others, which is, again, an important step. And already some of these genes, such as PNPLA3 and TM6SF2, are being looked at as potential drug targets for future therapeutics development. So very exciting seeing the discovery science moving all the way through from risk stratification through to potential hopeful new treatments. What we also see in this graph, I think it's probably best to look at the picture on the right-hand side rather than the graphs on the left-hand side. But what it shows here is that although our genetic makeup is locked in from birth, the way our environment and the way our body weight can influence it means that those genetic factors have a greater or lesser influence. So essentially, the risk conferred by the PNPLA3 variant is actually relatively small in individuals who are normal weight. But as we gain weight, the effects of that genetic variant become more and more important in terms of driving our risk of cirrhosis. So whilst we can't change our genes, what that means, of course, is that if we're able to get our weight down, if we're able to address the things that are causing fatty liver disease, we can at least reduce the damage that those genes are causing. We can mitigate against that risk. So that's a really important message here, because no matter what our genes are, we can actually improve fatty liver disease by changing the background. Another genetic variant, I think I've mentioned this one before to this group, is this gene TM6SF2, which again is very interesting. On one side, if you carry one variant, you get fatty liver disease. On the other side, if you carry the other form of the gene, you're more likely to get heart attacks and strokes. So this is a gene where we're understanding the risk as a master regulator of liver disease outcome. And again, that's an important idea because it helps us to guide potentially whether people should be channeled towards hepatology or channeled towards cardiology in the future. So another exciting concept here. We're seeing how the genes influence our risk, how they could be potentially used to guide our prognosis, but also that we can, if you like, compensate for our genes by changing our lifestyle. So very important ideas. So I'm going to move away now from that sort of discovery science and just talk a little bit more about diagnosis and risk stratification for fatty liver disease. What we know is that the more features of the metabolic syndrome an individual has, the greater the risk they are at. So in other words, if you are diabetic and have hypertension and have high cholesterol, for example, the risk goes up and up. And that's another important idea when we're faced with a large number of people who are at risk of fatty liver disease and need to focus down care. Unfortunately, standard liver blood tests are not very helpful to us when we're trying to diagnose fatty liver disease and risk stratify people. So there is a need for better diagnostic tests. And that's an area, again, where in Newcastle, we've now had a long period of research ongoing. As many of you know, historically, we've always relied very heavily on doing liver biopsies to truly assess the severity of fatty liver disease. And this makes complete sense. It helps us to confirm the diagnosis. It helps us to give information about prognosis in the future. And it also helps us to monitor the disease in terms of, is it getting better or is it getting worse? So it's understandable that there has been this reliance on fatty liver disease. I thought it might be useful just to show a little bit of histology and just to explain some of the things we talk about in the clinic. Because when we talk in the clinic, we always talk about the amount of fat, the amount of inflammation, the amount of ballooning, and the amount of scarring. And so they're quite sort of, broad concepts that don't necessarily mean very much. So when we look at the fat, it's these bubbles like in the aero bars that we're seeing on the biopsy. And then the ballooning are these very specific changes in some of the liver cells that indicate that they are, if you like, dying. And then inflammation, this is the white cells coming in to, as part of a healing or part of an inflammatory response. And finally, it's that scar tissue, which you can see here in that blue color, which is the bands of scarring forming that leads ultimately to cirrhosis. So those are the features we look for, and we score them using these different scoring tools, which I'm not going to dwell on too long, but the idea here is that we can, when we do a biopsy, we can give people some information in terms of the severity, not just of the inflammation or the fat, but also in terms of the scarring and read through on that. So that gives us some useful information. But wouldn't it be even better if we didn't need to do a biopsy? And I think that's really the direction that we have to hope and help move the field in. And that's an area where there's been a lot of research going on in Newcastle. And particularly this study that I've led now for a couple of years called the LITMUS Consortium, which again, LIVErNORTH has supported amazingly, and I'm very grateful, which really is part of a major international effort to move away from liver biopsy towards scans and blood tests to better diagnose and risk stratify patients, and to work with the regulators both in Europe, such as the European Medicines Agency, and in the United States, the FDA, to get these non-invasive tests licensed for use. There's still a lot of work to be done on that, but I am really pleased at the progress that's already been made over the last couple of years within LITMUS. We've had a number of letters of intent accepted by the FDA, which is a key step in moving biomarkers forward so that we can move the field away from histology. what have we got in terms of biomarkers? Well, we have a range of different tests that can be used. So for quantifying the fat in the liver, we have FIBROSCAN, which we use in the clinic in Newcastle, and also tools which are MRI based that are really very much research tools. When we're looking for inflammation, at the moment, there aren't many great non-invasive tests, I'm afraid to say, but that's changing. We've recently published a paper in the Lancet Gastroenterology on the NIS4 score as a potentially very useful tool, which is based on a combination of features, including some very special genetic products called microRNAs. But the area where we have the most diagnostics is for fibrosis and cirrhosis. And that's understandable because it's been the area where there has been most interest, not just in terms of fatty liver disease, but in terms of other liver diseases as well. And it also makes sense because we know that the more scarring there is in the liver, the greater the risk of death, either from a liver-related cause or from heart attacks and strokes. So greater scarring really is a very, very important indicator of prognosis and future risk. And so it's understandable that diagnosing this accurately is of real interest because it's the most valuable guide to long-term outcome for us. In the clinic routinely, we look for fibrosis using a two-stage process. So we use something here called the FIB4 score, which basically is a composite of age and some blood tests, including platelet count, and use that to categorize people essentially like a traffic light into red, amber, or green risk patterns. And then we follow that up with the FIBROSCAN to measure the stiffness of the liver and to further help us to qualify how severe the liver disease is. So this is the pathway that we use in the clinic in Newcastle. So reading from the top to the bottom, we calculate the FIB4 score. If we find people are low risk, that's great news. It means we can give some reassurance. We can also give some lifestyle advice to address the risk factors, and those patients can go back to primary care. If, however, they're in the amber or red category, we then do that FIBROSCAN to measure the stiffness of the liver. Again, if it's low risk, lifestyle advice, reassurance, back to primary care. But if it's intermediate or high, in selected individuals, it does remain necessary to do a liver biopsy and to really accurately grade the disease and stage the disease. So these are the important areas here. I've already spoken about this idea of this balance between scar tissue being laid down in the liver, what we call fibrogenesis, and being broken down and reabsorbed, what we call fibrolysis. And one of the exciting developments here is the development of a number of blood tests that help us to look at this balance, because of course, understanding that balance is very useful, not just in terms of telling us where we are now with scarring in the liver, but hopefully it will be informative in predicting how quickly that disease may get worse, or whether in fact it's not going to get worse at all, which would also be incredibly useful. And so we now have a number of tests that are being assessed for their utility in this one. One of them is the ELF test, which has been around for a number of years, and we're still studying that further. In terms of its performance, it's not massively better than the FIB4 score or the NAFLD fibrosis score, but it does potentially give us more information on the dynamics of scar tissue. And then the new kid on the block is this new test called ProC3 that actually we published on last year, looking at the performance of this test in the Newcastle cohort. And again, we were able to see that greater levels of this marker, which is a marker of basically of scar tissue deposition in the liver, the levels go up as the amount of scarring in the liver goes up. And this has allowed us to generate a number of scores and diagnostic panels that are currently being assessed within LITMUS to see if these may add greater value to the diagnostics. So there is already then a great deal of progress using these off-the-shelf biomarkers, which is a great start here, although at the present time, few of them are truly ready for prime time in clinical use beyond the ones we already use in Newcastle. We've taken the approach, however, that we don't just want to accept the things that have been developed or found in the past. And so this is some research that is literally just coming out in press in the next few weeks. So I'm delighted to be able to share this with LIVErNORTH as one of the first groups who will be seeing this data. And I think that's particularly fitting, as it is, again, of course, patients from Newcastle and from other parts of the UK and Europe who've made this research possible. So what we've done here is we've taken liver biopsy tissue at the same time as people have been having diagnostic liver biopsies in the clinic. And many of you who've had a biopsy in Newcastle will know that Elspeth and Lorna are often hanging around with a flask of liquid nitrogen to pop a little bit of the tissue into this, and then it gets rushed off to the lab. And what we've been able to do is we've been able to extract what's called the messenger RNA from that. At that moment in time where it's come out of the body, we've been able to see which genes are turned on, which genes are turned off, how they're interacting, and so on. And this has been incredibly useful. So in a cohort of just over 200 patients' livers, we've been able to look at this, and we're seeing different patterns of how the genes are turned on and turned off, separate to the differences in the histology, and potentially therefore more informative, because it gives us new insights into the differences between different groups of patients, better than we can just see looking down a Victorian microscope. So this is a very exciting development into dividing subgroups of individuals. And we've gone further than that. We've been able to pull out a 25 gene signature from the liver that actually helps to discriminate between early disease and worse disease with greater scarring of the liver. So again, a very useful tool in terms of accurately studying the severity of liver disease. And then, because of course everything I've talked about here requires access to liver tissue, we've been able to go beyond that and actually look at some of those same genes that have been turned on. We've been able to look at the products of that in the circulation, and have identified some proteins that flow around in our blood that actually, again, correlate with those gene changes in the liver, correlate with the severity of the disease, and so potentially are going to lead to new diagnostic tests that we're again studying. And one of those is this GDF15 I'm showing you here, where if you look at the bottom right-hand graph, you can see that the levels of this go up step by step as the scarring of the liver moves from no scarring, F0, all the way up to cirrhosis, F4. So the start there of a really exciting new chapter in diagnostics. So change of pace now. We've talked a lot about the underlying changes and variation in the natural history. We've talked a bit about how we diagnose the disease at the moment and where I want the disease diagnosis to go in terms of much more accurate non-invasive tests, which is what we're all working to. What I'd like to do now in the last 5 or 10 minutes is just talk a little bit about where we are now with treatment for fatty liver disease, some of the work that again has been going on locally and internationally to improve the treatment for fatty liver disease and to understand things better. So again, I think it's always important to take a step back, because the reason we have fatty liver disease is complicated. There are this squirrely picture of multiple blobs over here is not an attempt by the UK government to work out their strategy for Brexit, but in fact is a chart of all the potential interactions which lead to people being overweight or obese. And this was produced by what's called the government's foresight report a couple of years ago. And as you can see, it's complicated. It's due to the environment we live in, whether it makes it easy or difficult for us to be active, to take a walk, to use the stairs, to exercise. It takes into account our individual psychology, the pressures on us from society at large and on the individual, our relationships with food as a society and as an individual, and then our physiology, what's going on inside our bodies. And all of these lead to this complex web of interactions that drive our risk of gaining weight, and of course also drive our risk of fatty liver disease. And so at the heart of treating fatty liver disease is a need actually to address this on a societal level as well as an individual level. And that's probably outside the remit of a doctor, but it's something that we need to think about, particularly when you consider this survey that we published earlier this year, where we've looked across Europe and discovered that virtually no countries in Europe have a clear national strategy for how fatty liver disease will be addressed. And that is a pretty worrying state of affairs when we start off with the concept that a quarter of us have fatty liver disease. So a very complicated situation, very complicated drivers for this disease. And importantly, this disease also has huge impacts on us as individuals, not just in terms of our liver health, but increasingly in terms of affecting how we feel and function. And I haven't got time to share all the data with you now, but fatty liver disease, as you know, has historically been considered a condition that is asymptomatic. It's silent until people wind up with cirrhosis. And as we've been working to study the disease more, we've developed increasingly specialized tools to understand quality of life. And again, many patients, many of the members of LIVErNORTH have helped us with this. And some of the questionnaires we've been doing in the clinic, and also some of the work we've been doing at the university about how it feels to have fatty liver disease. And what we now understand increasingly is that having fatty liver disease affects our mood, makes us more likely to be tired, makes us fatigued, can affect whether we are feeling a bit low, a bit depressed, leads to abdominal pain, so pain in the tummy, and a whole range of other symptoms that up till now doctors have not understood. And so this is another important area where we begin to learn about the disease. But what about treatment? Well, there are 4 steps to treating fatty liver disease. We have to target the overweight and obesity and see what we can do about that. We need to target the metabolic syndrome. So that's those risks for heart attacks and strokes, because we know the more of those risks that are present, the greater the chance of a heart attack or stroke, and also the greater the chance of having advanced liver disease. And then we need to find medicines that will target the liver disease and finally reduce the risk of downstream complications such as liver cancer. So it's a whole package of work, and all of it needs to be pinned back to the fact that each of us is an individual and is affected by all those societal drivers and the environment in which we live. We know that lifestyle change, by which I mean particularly diet, but also exercise, is beneficial. We know that if individuals are able to lose between 7 and 9% of their body weight, whatever they start out at, it will be beneficial in terms of improving the NASH, the inflammation. We know that if people can lose more than 10% of their weight and keep it off, that will help in terms of healing the scarring. But also, we know that many of us lack confidence to go to the gym and start exercising, or find it very difficult to make and sustain the necessary dietary and lifestyle changes. And, you know, that's understandable. It is a complex world we live in, right now, possibly more than ever before, it is a complex world. And so it is difficult to make those changes. Now, booklets like this one, which we've generated with LIVErNORTH, I hope are a small step in the right direction, at least in terms of signposting the sorts of small changes that we can do that will help to improve the situation, so that we can each take ownership of fatty liver disease and begin to address it. There's one other aspect of lifestyle that I wanted to talk about. I started this lecture saying very clearly that non-alcoholic fatty liver disease is not caused by alcohol, and that's absolutely true. But again, some emerging data is showing us that even modest amounts of alcohol, well within the government recommended amounts, can still compound the damage that is taking place in our livers. So the red boxes here are highlighting what essentially is the allowed amount of alcohol that people can consume, somewhere between 20 and 30 grams a day. And what you can see is that as the graphs move up, the risk of having more advanced liver disease increases steadily. So, for example, the most obvious one is on the right-hand graph, looking at type 2 diabetes, where you can see that individuals with diabetes, the pink zone of that, are at substantially greater risk of having advanced liver disease, even if they drink only a modest amount of alcohol, than non-diabetics. And it's this idea of multiple hits on the liver interacting and contributing disease. So whilst alcohol isn't the cause, as part of our thoughts about lifestyle change, we do need to think about this because it's part of the drivers of the condition. How can we address it? Well, here's some data from a very nice study that we've just published, which is led by Kate Halsworth and some of my colleagues, looking at very low calorie diet. That's that 800 calorie a day diet. And what you can see is that a period on that has led to improvements in the blood tests and definitely improvements in terms of liver stiffness, suggesting that this sort of approach, although to be honest, not the nicest diet in the world, is certainly a very effective way of bringing weight down and helping liver tissue. We also have a study going on at the moment that is being led by Laura Haig in the clinic. Now, this one's a slightly different one. So instead of just looking at restricting diet and going on a strict diet to try to bring weight down, what this one is about changing the diet. And it's basically, it's a 3-month study, 1 month of which we provide you with Mediterranean diet ready meals that are delivered to your door, so that each week the majority of your meals are of this Mediterranean diet, you know, high in olive oil, high in fish, and so on, and very healthy food. And then the other 2 months, it's your standard diet, and we do some series of blood tests and scans to try to understand how that influences the inflammation and the scarring in the liver. And we're currently recruiting into this, so please do spread the word. If anybody is interested in participating, Laura's contact details are there, and we would be delighted to hear from you. So that's one of the ways that we can address this. The other way, of course, is drug treatment, medical treatment. And no drug can ever truly replace lifestyle change, but it will be, I'm sure, ultimately an important part of our armory as we fight liver disease. Now, it's important that I say that right now there are no licensed medical treatments for fatty liver disease. So everything I'm going to talk about from here on in is experimental, and we don't yet know whether any of these medicines will be licensed in the future for fatty liver disease. So this bit does come with a bit of a health warning in that respect, just to be very clear. It's also worth saying, because of limits of time, I'm just going to pick out a few examples. I can't possibly go through all the different medicines. So we've talked about the 4 targets, and really we've already begun with existing medicines to start to address them. one of the big things I want to highlight is that statin treatment to reduce cholesterol is by and large safe in fatty liver disease. So a message which I think is really important we put out there is, please don't stop statins if you're told you have fatty liver disease. There's a significant risk of heart attacks or strokes, so it's very important that we do keep that going, and it is largely safe. I keep saying that the pathophysiology is complex, and you're all going to be very relieved that I'm not going to even attempt to talk through this slide, apart from to say there are a huge range of different aspects of what drives the progression of fatty liver disease that could be targeted with medicines. And in fact, we're now in the situation where there are over 70 clinical trials running around the world at the moment, all looking at different medicines. And I've just pulled out some of the medicines here. So what you can see is that the majority of the medicines are at the left-hand side. They're addressing insulin resistance, how fat is handled in the liver, and how that fat can cause damage to the liver cells. So they're, if you like, metabolic drugs. And then on the right-hand side are the medicines that come later in the pathways, targeting inflammation or trying to stop the scarring forming. Sadly, some of those medicines have already fallen by the wayside and have been proved to be unsuccessful targets, and I've shown that there. But the more eagle-eyed of you will notice that there's one in green, which is Obeticholic acid. Now, this is a medicine that's already licensed for PBC. So it's a medicine that is already out there for a different liver disease. And there have been a series of increasingly encouraging studies looking at how this performs for fatty liver disease. And just slightly less than a year ago now, the Regenerate study read out its 18-month interim analysis. So you can see that there in amber. Now, this study had two possible endpoints. It was either looking for an improvement in scarring or an improvement in NASH, in inflammation in the liver. And in fact, what the study showed was that this medicine did statistically significantly improve scarring of the liver, but it didn't do very much, at least in this study, for the degree of inflammation in the liver. So it was a curate's egg, good in parts in terms of its response. But right now, this is the first medicine that has met its primary endpoints at a phase 3 clinical trial. So this is a very encouraging thing. And what you can see here on the right-hand side is that people on the higher dose, more of them had an improvement in fibrosis, but also of people taking it, fewer of them had a worsening of fibrosis compared with placebo in green. So very encouraging in terms of demonstrating that this drug does indeed have efficacy in terms of the histology and improving that aspect of fatty liver disease. That trial is now carrying on because, of course, it's important for us to demonstrate not only that it improves a biopsy or a biomarker, but it also has to translate into long-term improvements in outcome and wellness of patients. And over the next couple of years, I think we're going to see the results of that coming through. It would be remiss of me not to highlight, and this is an edited list, but of course, all medicines have side effects. And for obeticholic acid, that is no exception. Some of the most common or troublesome side effects are that it leads to itch, it leads to pruritus, it can increase LDL levels, which are, if you like, the bad cholesterol, although that can be controlled with statin therapy. And there is also some evidence coming out that increases the risk of gallstones and other biliary problems. So with any medicine that is efficacious, there are, of course, always some downsides to it. And so at the moment, this isn't licensed for treatment, although it may well become licensed for treatment in the next year or so. And of course, its use will then have to be on a case-by-case basis, weighing up the risks and benefits. What I wanted to finally do is just introduce another medicine to you here, which is the one shown in red in the middle of the graph. So One of the key features and one of the early readouts in drug trials is how effective the medicine is at reducing the amount of fat in the liver when it's measured by MRI scan. So the obeticholic acid I've just shown you is the blue bar on the very left-hand side, which showed an average reduction of about 17% in terms of the amount of fat in the liver. But the compound in red, MGL3196, as you can see, was much more powerful at reducing the amount of fat in the liver, down to about a 58% reduction of liver fat at an 80 milligram a day dose. Now, this compound, which is called resmetirom, is now actually entering a phase 3 clinical trial, and we're now recruiting for that one in Newcastle. So again, we have a range of different trials ongoing, some of them lifestyle changes like the Mediterranean diet study, but also this is just one example of a number of the studies that we currently have recruiting in Newcastle for medicines for fatty liver disease. So again, always very keen to hear from people if they are interested in participating. So I think that brings us to the end of this chat, and hopefully I've not gone on too long. Fatty liver disease is a highly prevalent but largely asymptomatic disease. Fortunately, the majority of us who have it will not be affected, but there are a significant minority who will run into problems. And so it's very important that we identify them and address this as best we can. And there are now substantial progresses being made in understanding how the disease progresses and also developing better diagnostic and treatment approaches, although at present, lifestyle change remains the mainstay of treatment. Just leaves me to acknowledge all my colleagues in Newcastle in the liver clinic and also in the labs, to thank our funders and in the LITMUS consortium and EPOS, and particularly to thank LIVErNORTH and all the patients across Europe who are really supporting this work by helping us to understand the condition better. So thank you all very much indeed for your time now, and I'd be happy to answer any questions if anybody wants to.
Thank you so much for that, Quentin. Absolutely marvelous. What it told me was that there's absolutely a huge amount to know about non-alcoholic fatty liver disease, and it's almost impossible for a GP to take all that in, understand all that, and it's always been one of our helpline guidelines is that you need to see a hepatologist. You know, people say, can I take this? In fact, one of the regular questions is it okay to take urso? And we say, you must go and see a hepatologist. Only the hepatologist knows what's going on in your liver. And I think that's so important, and a GP couldn't possibly understand all of that. It's just immense. Not that I've got anything against GPs, I just think you've got to really understand it. Yeah, I think I've unmuted everybody if anyone wants to talk. You can unmute yourself as well if you have any questions for Prof. Anstee.
No, it answered the question. I was going to ask you about Obeticholic acid.
No, stunned silence. I mean, what I hope I've showed there is just the breadth of this, and you know, all of this work is going on in in Newcastle as part of a global effort to address it. And I can see Leah's on the line here. She's obviously been heavily involved in a lot of the symptomatic work, a lot of the quality of life work, and the psychology of this. And it's a fantastic team effort, and we're very lucky to have such great colleagues, and also everybody's contributions in the clinic, because we really couldn't do this without an amazing group of patients who are willing to join in and take part in these things.
This is fascinating.
Transplant patients participated in the trial. Would the fact that they're on any of the meds that they're on, would it affect any of the results of the trial?
Yeah, so unfortunately at the moment, people with transplants can't take part in any of these trials. You know, what we're doing here is we're trying to identify whether the drug works in, if you like, the most straightforward population. And exactly as you've said, the complexities of the interactions with the medicines for the transplant and everything else would make that more difficult. I hope in the future, once we understand which of these medicines are most effective, it may well be that at that point we are able to use them in the transplant setting, because of course we know that fatty liver disease can recur post-transplant in the graft. And so that is another, real area for the future to address. You're absolutely right.
So could any of people with liver disease take part, or is it no one with any type of liver disease?
It's patients with fatty liver disease. So anybody with fatty liver disease, we are very keen to enroll. Every trial has different entry criteria, so it isn't a one size fits all. And because we operate so many trials in Newcastle, we fortunately have the capacity to be able to put, if somebody wants to be in a trial, more often than not, we can fit them in a trial somewhere. So everybody has the opportunity to contribute to improving this for us all, but also hopefully to gain some benefit from themselves wherever possible. So it's hopefully a win-win situation.
I'm wondering if there are any plans afoot to improve public knowledge about fatty liver disease and how it might be prevented when it's such a common thing.
Absolutely. And, I mentioned to you this survey we've just done across Europe about the fact that there's actually almost no government public health response to fatty liver disease in any country in Europe. This isn't just the UK, this is everywhere. So there is certainly a drive to do that. It's something that I'm quite heavily involved with. And also I think things like LIVErNORTH have some leadership. I know I've seen Yvonne's on the line. She came down to a meeting at the European Medicines Agency and gave a fantastic patient perspective on why this condition matters. And it's by doing those sort of things that we can chip away and actually get this out there. But it's a really important part of it. I couldn't agree with you more.
Thank you.
Any more questions? No,
yeah, can I ask a question?
Yeah.
Yeah, hi Quentin.
Hiya.
I don't know if it really is a question, but well, I guess it is a question, but just thinking about COVID and how all of our lifestyles have been massively affected. And I definitely have gained corona stones during the lockdown and have not been doing as much exercise and have been overeating and all of those things. Are you seeing any effect of this crisis on things like NAFLD? Okay,
so I think it's a key point. I mean, we all know that we've all put on a bit of weight with lockdown because none of us are even walking to the bus like we used to. And to be honest, we've all probably had a couple of glasses more wine more than we normally do as well. So it's been a bit of both going on with lockdown, certainly in my household. So it's a complicated situation. It's probably too early for us to see it reading through because fatty liver in particular is a slow disease. I think of it like a stalker. It's there with us for a very long time before it pounces. And that's the problem with it. But I think we will be seeing a readout. For conditions like alcohol, we're already seeing a readout, particularly in people who have problem drinking, where obviously things happen very, very quickly. So yes, I think across the board in liver disease, sadly, we're going to see, problems coming out over the next years as we read through to this. And that's, a great challenge. The other thing we've seen is I know a lot of people in the clinic who've been making huge efforts to bring their weight down and have actually been doing really well with it. 6 months stuck in the house has undone a lot of people's excellent work, which has been hard fought. So there's a lot to this. You're absolutely right.
Mm. And I guess the other thing that I often think when I hear about the very low calorie diet or the highly restricted calorie diet is, I know it has to be done under medical supervision, but is that being used for other conditions as well?
So VLCD, there was a large trial actually done in primary care a year or two ago, which has demonstrated it's been highly effective at reversing type 2 diabetes. And that was the work of Roy Taylor, who, again, a senior academic from Newcastle, who's really spearheaded this. The NHS has adopted it, and it is going to be rolled out as I think, a test, really, in a limited number of individuals to try as a therapy for type 2 diabetes. The data I've shown you there is particularly good because it shows, and you know, to be honest, it's not rocket science. If it's good for diabetes, it ought to be good for fatty liver disease. What we're seeing there is certainly very encouraging signs with it. I think there's more work to be done, and we've just applied for a grant to actually run another study with VLCD, which would also include biopsies and so on. So would give more insights into this of the same level that you'd be required to license a medicine, because this is one of the strange things at the moment. To get a tablet license, there's a very clear pathway to prove it works. Whereas for something which is quite complicated, like a diet, and requires an awful lot of willpower and stamina to stay the track, there's no requirement to prove it works in the same way, which means that there's an awful lot of phonyism out there. And so we have to be, you know, clear about everything and show that things work properly. And I think that's a very important aspect of this.
Thank you. You can tell I'm worrying a bit about my weight at the moment, but thanks for that. That's interesting.
No.
Dr. Quentin, can you hear me?
Yeah,
yeah,
Trevor, is it?
It
yeah,
is,
hi,
yes. If someone, in the last slide, it said about there's medication to obviously reduce fat. If someone has already lost more than 10% of the body weight, can they still take part in those medication trials, whatever? So
that's a really good question. It would depend when they lost the weight. So for example, if somebody lost the weight a couple of years ago and now their weight was stable, we'd have to re-biopsy them to assess the situation now, but yes, they could. What we wouldn't want, or what we're not allowed is what I should say, is people who are actively losing weight at the moment, because of course we know that losing your weight is good, and therefore it would make it harder for us to work out if the medicine was having a benefit or if it was just the weight change. So that it's a slightly nuanced answer to that one, Trevor.
Right. Okay.
Yes. But if weight is broadly stable, we'd certainly be interested. But it's a case-by-case thing, and of course we'd have to discuss it, and you know, we'd have to think about it. You'd have to think about it and decide if it's what you want.
Yeah. Okay. Thank you.
In one of the later slides, you mentioned the intestinal microbiome. Mm. And I was thinking about those drinks like Actimel and Yakult and so on.
Yeah.
Have they?
Yeah.
Have they got any role?
Probably not, is the short answer. There's certainly no evidence for them to. There are some questions about how much of the bacteria survive through your stomach acid anyway. So I'm not aware of any data to support their use in fatty liver disease. Doesn't mean they're bad for you, just not sure that they're beneficial, and they're certainly expensive. So, you know, that's the other side of this.
Thank you.
Are people actually tested to be recruited on these trials? Do you know how you're made aware of somebody actually going on to them or doing tests in order to get them onto the trial? Where do you get your patients from?
Okay, so we recruit patients from the clinics in the Freeman. So this is people who are being seen for standard NHS care, people coming from their GP, people already being seen in those clinics. People are always welcome. You know, my view is that we recruit into these trials because it's how we advance the field. It's also the way, by me running these trials, it gives the patients every possible opportunity to access any treatment as it's coming along, okay? I don't know if they're going to work or not. we all find that out together. But it gives the patients who are coming to the clinic, sorry, my headphones are dying, so I'm just going to unplug these and hopefully you can hear me in a second.
No, I can't hear you, Quentin.
Can you hear me still?
Yes, it's better. Yeah.
Okay. Yeah. So by doing the trials, basically, I hope it gives people as many options as possible to access potential new medicines before they become available. Of course, we don't know if they work. That's why it's a trial. So there's no guarantee with any of that. But it gives people more options than just the standard NHS care, which is, I say, eat less, run more, and I'll see you in 6 months. So I want to do something a little bit more than that, really.
Excellent. Any other questions for Quentin? Brilliant. Well, we'll be asking our secretary, which is Sarah in the liver office, to come along and make a small presentation to you. She'll be at work, so she'll be catching up with you sometime in the Freeman and making a small presentation on behalf of all of us, and we'll have a photograph for the Liver News, if that's okay with you.
No problem.
What I would like to do now is to ask everyone to witness the draw for the lottery, if that's okay. Yeah. And then we'll move on to a couple of other things. But can you see this bag? This bag?
Highly technical.
Yeah, we can see it.
I'm going to put my hand in and draw out, but I've got nothing in my hand. You see that? Nothing at all. A bit like Tommy Cooper. Here's the number 180. And we'll just tell you who's won £250. And I'm going to say that this was drawn by Professor Quentin Anstee, because it looks a bit favoritism if it's somebody I know.
Someone called John Bamborough.
John Bamborough. So we don't know who he is, but we'll be writing to him and saying thank you for being a member of the club. A couple of other things to announce. There is a committee that's been formed at Newcastle University called the MIC. It's a terrible acronym. It stands for the MedTech In Vitro Diagnostic Committee, and we're looking to recruit people. If anyone is interested in helping with assessing research, this isn't looking at the research itself. It's assessing to see whether or not the research is valid, worthwhile, and to help the researchers come up with projects to see that the public and they want public opinion. So if anyone's interested in that, please get in touch with me. I don't know if you've heard about it. Anyway.
Not anybody with medical knowledge, that, John?
No, public, members of the public. That's what they want. They want the public to say whether or not they think this research is worthwhile, and they go to great lengths to explain to you what the research is about and whether or not we think it's valid. It's a different thing to being on an ethics committee. It's a different thing to being PPI.
It used to be called the DEC, which was easy to remember because that was just a diagnostic evidence committee. And Tilly and I, years ago, went down to Leeds and we actually got involved with the ELF test and, did all sorts of things. And then they changed the name to MIC for some obscure reason.
Yeah.
And Newcastle have started it as well. So John and I are both involved at the moment with the Newcastle MIC. I'm still involved with Leeds, but we're looking for new members, mainly because I'm now very old and need to retire.
Yeah, it was a big birthday for Joan yesterday. It was the day before, sorry. I put on Facebook that I made her some a champagne and caviar breakfast. I didn't have any champagne, so I made her a cup of coffee, and I didn't have any caviar, so I gave her Rice Krispies. But it's a thought that counts.
Exactly.
Is it?
Anyway, Quentin, thank you so much. If you want to leave us, you're more than welcome, but we're very, very grateful to you. It'll be appearing, I'll do some editing, it'll be appearing on our YouTube channel
Okay.
Before you go, you did mention that the gene sampling was a good indicator of whether or not people were more susceptible to, you know, to non-alcoholic fatty liver disease and cirrhosis. And we can't do that except by biopsy. Sorry, we can't actually look at the genes except without a tissue sample.
So it varies. For genetic variation, we can do that actually on blood or saliva and lots of things. But when we want to look at gene expression, which is that route I showed from getting from the liver tissue to that marker in the blood, the GDF15 marker, that one required us to have liver tissue. The hope is that we can, because we've been able to show that we can detect something in the blood that started in the liver, the future is that we just look at the blood. But that's how we, that's how you discover them, is you start at the source and you track it all the way through. So it was just another example of some of the work we're doing. Again, and I really have to stress this, thanks to the amazing support of LIVErNORTH members by allowing us to, you know, have these samples, because they are a phenomenal resource that we're using as a very precious resource to help move this field forward.
Can I, John? Can I just say, John, from my point of view, I'm guessing that a little bit of my sample might actually be part of that. And can I just say, if you don't mind, John, I was diagnosed at the time Professor Anstee actually came to Newcastle, and I also joined LIVErNORTH at the same time.
All right.
And in the field of NAFLD, I always felt really frustrated that I didn't feel that there was that much going on in terms of research or anything. And the length of time that I've been part of the system, if you like, and part of LIVErNORTH, I can't begin to say how much we really appreciate Professor Anstee, because not only is he an outstanding speaker, but he's obviously an outstanding doctor. And I just want to say thank you, because listening to what was happening at the beginning of all of this and listening to what we're listening to now is just, it's overwhelming. It really is. And I just want to say thank you as a patient as well.
Well, that's incredibly kind. Thank you.
Well, I'd also like to say, Quentin, that, and I'm always banging the drum on this when I'm at the governor's meeting. This is the hospital governor's meeting. The volunteers do it on a voluntary basis and don't get any pay whatsoever. And the only way to thank them is to have people like yourself coming along and saying thank you. And you've done that today, which is absolutely fabulous. So this is our payment, you saying thank you to us. So we're very grateful for that.
And I'm hugely grateful. It's a great pleasure and an honour to look after the people I look after in my clinic. So thank you.
That's great. And also don't forget that if you want us to publicise Laura's trial or any other trials, we're more than happy to do it using our social media, which is now the main way of communicating, apart from our newsletter, of course. But, that's good. And your Brexit slide is brilliant. We'll be using that to send it to the government. Yeah. So that's about it, folks, unless anyone's got any other comments to make. Thank you very much.
Thank you.
Thank you. Thank you very much.
Thanks very much.
Bye.
Bye, everyone. Bye.
Bye.
Bye. Bye.
Bye.
Bye, everyone.
Bye.
Bye.
Bye. Bye.